Okay. Let's go ahead and take a seat. Also, I'd like to remind you that in committees, we're wearing masks. So if you have one, please put it on. We have some members that are very sensitive to that. Understandably, they've had friends and relatives pass away, even vaccinated. Today, we're very fortunate to have two folks I've known very well over the years. Jesse Wethington, he's actually, some of y'all know him from his work at the Capitol. He was helped our budget committee, among other things, healthcare budget. He's very knowledgeable, one of the most knowledgeable people in healthcare financing around, other than Representative Butch Parrish. And also with him is Blake Fullenwider. Blake is actually from Gainesville. His daddy and I went to high school together and played some sports. His daddy's a very well-known surgeon, actually left Emory to come back to Gainesville to raise his children. Blake, as you know, was with DCH. He's now in the private world. And what we're going to discuss today is something that we've been talking about, Jesse and I and Blake, over many years, and that is the information behind the healthcare in the state of Georgia for CMO, state health benefits, and in other areas. We've had a little problem with seeing contracts, although it's been said that we can see them. I don't know exactly how you do that, but one of the problems, understandably, is that we have contractual agreements in there that cannot be seen publicly because they're in bidding contracts, so that's understandable. And also, if you look at the contracts, it looks like, and I've seen a couple of them, it looks like how you build a microwave oven or something. I mean, they're very complicated and convoluted. So Jesse has volunteered to start providing us information. Jesse and I will be working on some legislation to make this an annual thing. We have, over the years, providers and insurers have been fighting among ourselves, as you know. We say that they don't pay enough, or they deny treatment and medication that we feel that is very beneficial to a patient. Their reply is that we overcharge, or sometimes request procedures as unneeded. So that gets caught up, the patient gets caught up without anything and nowhere to turn. That's not a solution for the people of Georgia. It's also not a solution to keep the federal government out of the rest of our health care. If we don't get this thing fixed, we may well be seeing more federal takeover of health insurance, which you're always better off when you can look at your provider or your insurer and talk about problems and things. So enough of that conversation. Let me introduce Jesse Wethington. Thank you, Jesse.
Presentation teed up here, and without further ado, we'll get started. Can the members online see that? All right. If there's any issues, just stop us and let us know. So thank you for the chair. Thank you for the introduction, Mr. Chairman. Again, I'm Jesse Wethington. I'm here as the executive director of the.
Did you share it?
Yes, I think so. All right. Thank you. I'm here today as the executive director of the Georgia Quality Healthcare Association, which represents the managed care industry and Medicaid. Those, for your information, those companies are Amer Group, CareSource, and Peach State Health Plan are three CMOs that service the Medicaid population. As the chairman said, I've got a background in budgeting. I used to work at the department as well as the budget office here. I'll let my colleague introduce himself as well.
Great. Thank you, Jesse. And thank you, Mr. Chairman, members of the committee. It's a pleasure to be with you finally in person. It's great to be back at the Capitol. Blake Fullenwider with the Georgia Quality Healthcare Association. Have spent time at the Department of Community Health as the former Medicaid Director and Chief Health Policy Officer. It's a pleasure to be with you today.
So as the chairman stated, we want to give you some basic information around the program. There's been a lot of conversation in the General Assembly around transparency. Medicaid's been a hot topic for many, many years, both in terms of who is covered on it, what the cost of it is, and then the various provision of services across the different areas. And as you know, Georgia is hybrid in that it has part of its population in a low-income Medicaid program, which is managed by our CMOs, as well as the fee-for-service program, which is directly administered by the state. So the evolution of the program, real briefly, in 1993, Georgia kicked off its initial primary care case management program, which was called the Georgia Better Healthcare Program. That ran for a number of years. Then in 2006, the administration of the General Assembly decided to embark in this experiment in managed care. So the salient difference between that, of course, and fee-for-service is that the CMOs are paid at a prospective risk-based rate called under a capitation program. And the initial CMOs were WellCare, Peach State, and AmeriGroup. In 2008, the General Assembly passed House Bill 1234, which implemented a comprehensive regulation of the low-income Medicaid program known as Georgia Families. In 2011, that's not listed here, but while we were at the department for our first stint, the administration entered into a consulting report that resulted in a study called the Navigant Study that recommended some changes to the program. One of the after effects of that was the launching of the Georgia Families 360 program, which serves foster children. In 2017, the program was reprocured and a fourth CMO, CareSource, was added. In 2020, WellCare was acquired by Peach State, and so we've now gone back down to the 3 CMOs that we have today. And then, of course, in 2020, the impact of the COVID-19 epidemic was felt, of course, in Medicaid very heavily. And so that led to a number of directives, including the suspension of utilization management, prior authorization activities, certain program integrity activities, and the disenrollment of any member on Medicaid. And that, of course, was for both the fee-for-service and the managed Medicaid plans. So just briefly, a little bit of the benefits of managed care. That's who we are and who we represent. They do provide cost avoidance and predictability to the state. You know, we don't like to say savings in the context of Medicaid because spending never really decreases year on year, but there are ways that you can be more efficient and seek value in the deployment of your benefits. We limit the risk to the taxpayer. The per member per month premium that is received by the CMO is the extent of the state's liability. If that individual's cost of coverage exceeds that PMPM, then the companies are at risk for that. Cost avoidance. So in 2016, we engaged independent actuarial firm Wakely to look at the historical trend for the program. And so for that 2006 to 2016 10-year period, the managed care companies were able to deliver an average of 12% cost avoidance, i.e. your spending would have to have been on average 12% higher in a given year without low-income Medicaid being through a risk-based capitation agreement. And that also principally achieves the savings through, wanted to highlight this, the increased utilization of generic but therapeutically equivalent drugs. Here's a little example for you about how critically important that is. So we see here a comparison. This little table is for Q1 in 2021 of one CMO. So this was their experience. So during that time period, they issued 49,000 brand name scripts at a cost of $37 million. And similarly, generic scripts for that same quarter were 714,000 at a cost of $14 million. So you see that the brand name drug expenditure is only 6.45% of the total scripts, but they account for 70% of the cost. And that's exactly what you'd expect. Generics are typically 7 to 8 times cheaper. And that's one of the things that CMOs really try to do is drive generic utilization in Medicaid plans. And we've been successful at doing that in Georgia. There's some benefits and outcomes in quality care as well. We reduce utilization to ER by assigning members medical homes and making sure that they receive care in the location where it's going to be most cost effective or preventive. And then we also are able to achieve enhanced care coordination through examples of avoiding like drug-drug interactions or having follow-up care actually being delivered to the member. And there's also an innovative side to the plans. We can move a little bit more nimbly sometimes than the state itself. That's one of the benefits that we provide in terms of being private entities. So we can explore innovative treatment modalities without having to have a state plan amendment or a federal waiver. to approve it. The differentiation between the CMOs allows for competition among the plans and also choice for Medicaid members. If they don't like their coverage, they're free to change and move to a different managed care organization. As well as, this is similar to, more similar to commercial type coverage or employer sponsored coverage than the traditional fee-for-service Medicaid benefit. So it is less of a jarring transition for a member whose family circumstances change, typically for the positive. And so transitioning from managed Medicaid to an employer sponsored or commercially available plan is a little bit different for transition. And so it does kind of help the member adapt to the market that they will receive if they're no longer eligible for Medicaid. So a little bit about value added benefits. This is a comparative analysis of the plan, but Blake, if you would treat on that a little bit.
Certainly. And I think this is a good example of how the CMOs are able to move a little more nimbly than the state in that regard. So those of you who have been in and around Medicaid for some time, Jesse mentioned the state plan, Medicaid state plan. It is the contract between the federal government and the state that directs how the program operates. It is a federal-state partnership. It is a state-based program. The federal government provides about 2/3 of the dollars and the state provides the remaining third. So whenever there's a change to the underlying state plan, whether that be through that contract or through a waiver or other vehicle like that, it requires federal approval. One of the areas where the managed care organizations can add value to the program is through value-added benefits. Jesse talked about capitation. The best way to think about that is a premium payment that the state pays on behalf of a beneficiary while they're enrolled in a CMO. Now, what falls outside of that are these value-added benefits. And so the plans look both in the state and what they do in other markets nationally to determine whether or not there is a benefit to adding a service that is not directly reimbursed by the state. Some of the things that are really coming to the forefront now are things like gym memberships. There are home delivered meal options. There are things such as wellness incentives that over the course of really the last 10 years, it has tried to change the dynamic from looking at sick care to wellness. How do we get people into behaviors and a culture of wellness that can then lead to cost avoidance down the road? So here are a couple of examples of things that are currently available through the 3 CMOs. The department does approve these typically in the spring each year. And they are a way for the plans not only to attract members, but to help incent wellness and appropriate wellness activities. I want to touch real quickly on overall enrollment. And I think Jesse had mentioned that in 2017, when the new CMO contracts were issued, there were 4 managed care plans that all operate statewide. With the acquisition of WellCare by Centene or Peach State Health Plan, that has then reduced the number of managed care organizations down to 3. So you can see, based on 2021 numbers, overall enrollment, just under 2 million. That number has increased. Part of that is due to the Families First Coronavirus Response Act, which was passed by Congress in March of 2020. What that did is it provided state Medicaid programs a 6.2% federal medical assistance percentage, or FMAP, increase. So the share of the federal dollars coming into the Medicaid program was temporarily increased through the duration of the public health emergency. Now, what that also did is it put into place a maintenance of effort provision. And I'll touch in a little bit more specifics in a second. But right now, by my last count, there are just under 1 million Georgia Medicaid members in managed care and also in the fee-for-service program who may have been up for an annual redetermination of their eligibility. But by virtue of the Families First Coronavirus Response Act and the maintenance of effort provision, the state is prohibited from taking any adverse action on that case. The only examples would be if the individual moves out of state or they pass away, frankly. There may be 1 or 2 other examples, but by and large, those redeterminations have been paused until the federal public health emergency is expired. Now, Jesse and I were in Washington the last 2 days with the National Association of Medicaid Directors, and 55 of 56 states and territories were there. And the redetermination process after the federal public health emergency is over rose to probably the top 1 or 2 issues that states are going to have to deal with. It's going to be a very labor-intensive process, and of course, the administration wants to make certain that before adverse action is taken on an individual's account, that they are properly notified and that their appeal rights and all of those things are honored. So a lot more to come on that. It's still unclear in terms of, as we come out of hopefully out of the crux of the pandemic, what that time frame may look like, but I did want to mention that and note that these numbers have changed significantly since May.
Thank you, Blake. Chairman, I believe some of your members have a question, but I don't know if you wanted us to defer.
Just let's hold them.
To continue, so this presentation is entitled, Trends in Medicaid Budgeting and Transparency and Accountability. So this particular graph is a couple of years old now, but if you pull the current data, it would tell a similar story. This is a decreasing graph depicting the percentage of a county's population that's enrolled in Medicaid. And so this is one of the challenges you face, the department does as you determine Medicaid policy. So you get the left hand of the graph, I believe that's Decatur County, where more than 35% of the population is enrolled in Medicaid. That probably means that Medicaid is the largest source of payment for most healthcare providers in Decatur County, probably followed or following closely behind the uninsured or people who are on Medicare. If you look on the right-hand side of the graph, that's Forsyth County, where only 5.6% of the members or the population of that county is enrolled in Medicaid. And so it is a bit of a trick to make policy that sort of fits all, because we do have the issue of the one Georgians that's presented itself here again in this facet. So again, this is a graph depicting recent couple of years growth in healthcare expenditures. This is from the MMI. Middleman is a national actuarial firm, depicting the MMI typical family of four's healthcare cost on average in a year. 2020, interestingly enough, was the only year that they'd ever seen a year-on-year decrease. Of course, that is a result of decreased utilization of the pandemic. But we're here to tell you that it bounced back very quickly after the hard lockdowns ended. Additionally, there's a lot of pent-up demand for care that people were not able to seek during the pandemic that's come back. So you see in 2021, significant growth there. Middleman's projecting an 8.4% year-on-year increase from 2021 to 2022. That's, of course, larger than the growth in gross domestic product or healthcare increases over the past 5 years. This kind of breaks that same trend down by service. You can see for these various pieces: inpatient facility, outpatient, professional, pharmacy, and other. A little bit of a dip there in 2020 and 2021. We'll skip these on pharmacy for time's sake. So again, these are some of the key challenges we face moving ahead in terms of sustainability of Medicaid budgeting.
I mentioned briefly post-public health emergency unwinding and what that's going to entail. So currently, the Georgia Medicaid program is operating under a couple of various federal authorities, including an 1135 emergency disaster waiver, 1915C Appendix K, 2 waivers relative to things that have been relaxed. Jesse mentioned prior authorizations, and pre-approvals, things like that have been relaxed. And really, the reason going back to March of last year was continuity of services and making certain that as people were in a lockdown situation, people were discouraged from going really into a physician's office or emergency department unless it's absolutely medically necessary, but for fear of transmission of the virus. And so the idea is to make certain that as people were dealing with some of the administrative challenges, make it absolutely as easy as possible for them to maintain continuity of services. I touched on the redetermination issue. So there are just under 1 million Georgia Medicaid members over the course of 12 months following the conclusion of the federal PHE that are going to need to undergo a redetermination process. So this is going to require notification. It will require filing of an application. What the feds have made clear is to say, to the extent that DHS and DFACS have available electronic data sources through federal sources like the Social Security Administration, Department of Homeland Security, IRS, and others, that those data sources be used prior to asking an individual to provide any type of paper-based response to an application. So all of that's going to have to take place. There are appeal rights. So if an individual is notified that based on available data, they don't appear to continue to be eligible, then there is a process through which they're able to appeal that to the department and ultimately to the Office of State Administrative Hearings if it proceeds to that level. Patients First Act, I'm sure you're all familiar with the two waivers, the 1115 and 1332 waiver, which are in implementation, although with the change of the federal administration, there are new questions that have been asked. And so that work continues and also will require some IT infrastructure for implementation if those do indeed proceed as they're expected to do. Some of the other areas too is the cost and benefit of emerging therapeutics. And if you all recall, about 5 years ago, there was a budget line item for gene therapy drugs that you all included in the base budget. This follows in the same vein as large molecule biologic drugs, which are now about 10 years old in terms of its biosimilar approval pathway. Many of these new drugs are curative in the sense that they can treat very complex medical conditions. Some are orphan diseases, meaning that they affect a very small number of people nationally, but they're also extremely expensive. It was about 2 years ago, I remember and I don't recall the manufacturer, but a manufacturer who was close to getting FDA approval of a gene therapy drug came in to meet with me when I was at the department. We had a great discussion. It is a curative therapy, something that can bring a lot of hope to very sick patients. But towards the end of the meeting, I asked the question prior to their FDA approval. I said, do you have any idea in terms of what your price point is going to be for this drug? And they did not have that number completely solidified at that point. They had more work to be done. But what I was told, it was going to be just over $2 million per patient per year. And so this is one of those things that is going to continue to be a challenge. Again, these are life-saving drugs. They produce a lot of hope for very sick patients, but there is a balance in terms of the cost and sustainability to the programs in which they impact.
So that brings us to the next portion of our presentation and the proposal that the chairman outlined for you and that we've been discussing over the past several months. So the key to sustainability for Medicaid is to get ahead of some of these trends. We believe that in partnership with the state, that the managed care organizations that we represent are key to maintaining that stability. We've also heard loud and clear from this General Assembly that in recent years, the level of transparency or accountability has not been what you want as policymakers when you're trying to evaluate the Medicaid program. Now, I do want to speak up on behalf of my clients and let you know that we are incredibly accountable in terms of the volume of information that we have to provide to the department. We bury them, quite frankly, under information and reports. What you see here on these two slides are a listing of all the reports that we are required to generate over the course of a year. Some of these are done quarterly, monthly, or annually, but there's 78. They're comprehensive in terms of reviewing the scope of the program and different aspects of evaluating provider networks, looking at the financial performance of the plan, seeing if their quality metrics are being met. These, of course, do not include reports generated through open records requests, individual inquiries that may come through one of your offices, or continuous program improvement activities undertaken by the department. These also don't include the new reporting requirements passed under House Bill 946 in a most recent session. So there's some additional reports included there. These are some of the quality reporting metrics. They're currently 72, although that, there were 72. That's been trimmed down a little bit. Blake, if you would talk a little bit about the quality strategy that DC's implemented.
So as Jesse mentioned, there are HEDIS measures that are reported by the plans to the department and by extension to CMS on a routine basis. This is the Health Effectiveness Data Information Set, if you were interested in that. One of the areas that became very apparent a couple of years ago at the department, and work continues on that front, is really refocusing quality strategy and looking at all of the various measures and the issues that we know are most prevalent in the state. One that this General Assembly has paid a lot of attention to is issues related to prenatal care, maternal mortality, things like that. And if you look at also the bulk of the population who is covered under Georgia Medicaid managed care, they're predominantly children. So looking at well child visits, looking at asthma management, ADHD management, things like this, and reporting out in meaningful ways, it became pretty apparent that the department was tracking so many things, it became very difficult to focus on those key priorities. And so there was an effort underway to streamline that. And then through the annual performance improvement projects that the CMOs partner with the department on, go back and recalibrate and retool on an annual basis. This all falls also under the Office of Continuous Program Improvement at the department, which has been in place now for about 2.5 years, working in conjunction with the provider and advocate community to help identify those key priorities and hopefully move the needle in a positive way on that front.
So our proposal to you that we're to unveil today, and of course, this is the beginning of a conversation, not the end, as the chairman outlined, is that the CMOs are prepared to engage a third-party national consultant to generate an annual or semi-annual report to the General Assembly that reports in a comprehensive manner on key metrics that are important to you and other stakeholder groups. We've committed to partner with you all and the department in this effort, because we will have to do that in terms of accessing the fee-for-service data that they have if they want to make useful comparisons between the two programs. And we are interested in soliciting from you all various metrics that you would like to be included in this report. The data and metrics will be presented in an aggregated, graphics-heavy, and easily digestible format. That really is the struggle with this, is there is so much information, it's difficult to digest. And so the initial proposal is to put together the kind of high-level, useful data that you as policymakers will need to evaluate the aspects of the program, our performance, and goals for outcomes, quality, cost, whatever your priorities are. And then we will generate this report either on an annual or semi-annual basis, I say, to present it to this committee, Senate Government Oversight Committee, as well as the appropriations committees in the House and the Senate on a going forward basis, and we will come present that to you all each year. So what we're proposing to do is to recreate a report that was generated sometime in the recent past. You see a lot of examples from this excerpt. That's really the rest of the presentation. These are all examples from a report that was generated in 2013, so the data is quite old. And actually, I was able to obtain this through an open records request when I was in the budget office. And so this has, again, those metrics that you would be interested to know as a policymaker. There's been a lot of discussion around network adequacy, and we understand that's going to be a topic that will be up for discussion in the General Assembly in the coming winter session. Here you have a graphical depiction of it on this heat map. On the left, you see the CMO networks mapped out by county fee-for-services on the right-hand side, as well as provider counts for all the different providers that we have, as well as change in enrollment for the CMO networks and the fee-for-service networks. Here we have, and I'm going to run through these pretty quickly just because they're more examples versus the actual data since it's so old. Trending visits to the ER based off versus the number of primary care physicians. Top 10 hospitals based on inpatient admissions, CMO versus fee-for-service. Also has the planned paid amount and the number of claims and patients that they saw. Top 10 hospitals based on emergency visits. Again, comparing CMO to fee-for-service on the left and the right-hand side. Top 10 principal diagnoses in the emergency room. This is a map of the relative Medicaid Physician Fee Index. So you can see how Georgia stacks up in terms of our reimbursement versus professionals in other states or hospital facility type, however you want to slice and dice it. Again, this is old. Georgia has traditionally been on the lower end in terms of per person spending in the Medicaid program. That has been the nature of the program, I think, from the outset. And this also does not reflect, of course, the numerous fee increases that have been passed through the appropriations process by the General Assembly since this report was generated in 2013. So the picture would be a little bit different today. It's still a useful picture for you all to know. Here we have top 10 prescription drugs, CMO year-over-year cost per script. Again, given the population that we serve, you can see that it is largely ADHD medications or asthma, two conditions that are very prevalent in the child cohort. Fee for service is a different population. You can see it on there below, and they're typically spending money on their most expensive drugs are atypical antipsychotics or HIV, AIDS, retroviral medications. Next, we have top 10 clinical conditions by CMOs, year-over-year cost differential analysis. And below that, we have the same thing for fee for service. And again, that kind of shows you the acuity and the disease states that are prevalent in these two very different populations. Here we have a comparison of the age blind disabled. So again, that's another terminology for our fee for service program. The low income Medicaid program and Peach Care for Kids, which are managed by the CMOs. So you see a differential of the per person cost, enrollment, and then below that on the bottom, that's a comparison for the dually eligible population, which we haven't talked a lot about, but those are people who are both on Medicare and Medicaid. Next, we have, and again, this has been something that's been fairly interesting, I think, for different members of the Assembly. We have the capitation amounts by plan that have evolved over this period, and you can see an analysis that compares them and how those change and evolve over, this is a period of about, 8 quarters. So those are the kinds of things that we propose to you to put out and publish in the report. Additionally, we're going to make available this aggregated data, information that's relevant. A lot of those reports that you saw listed, things that are publicly available that don't have proprietary information, we will be publishing on a website. So it is easy to access, as well as a blank version of our shell contract, which of course is on the department's website, but we'll have that as well, just so that all these information, relevant metrics are at your fingertips when you try to evaluate us, the efficacy of your Medicaid program, and what direction you all want us to take as the ultimate appropriators and authorizers of this program. So, Mr. Chairman, that concludes our remarks. It's time to take any questions if there are any.
Thank you. The presenters had informed me when they first walked in that they had to leave at 2:15. They have a hard stop, so that's the reason I was sort of holding back on the questions to make sure they got through their information and presentation. We do have a few questions, so if you could make them fast. Representative Frazier. Yeah.
On the enrollment on the CMO, the page P4HB, the low numbers on it, who exactly is that? And I see the numbers are 1.8 million right now, and I know you said the numbers had increased. That's my first question. The second question is in reference to Blake, you talked about the federal funding 3/4 and 1/4. Is that based up on the numbers of constituents that have that's on the CMO? This amount, 1.8, how do we get those federal dollars? Is that based on numbers or?
So no, it's generally based on a couple of different measures. The federal medical assistance percentage, or FMAP, is the proportion of federal dollars that flow to the state. It is a fairly complex formula, but in general, it's looking at what the overall state poverty level would be. So if you're a poorer state, you get a larger federal match than a wealthier state. And that changes every year. Typically at the beginning of each federal fiscal year on October 1st, that's recalculated, and that number will change just based on how the economy is doing. To back up to your previous question, I believe the overall number right now is around 2.4.
Yes.
I believe it's around 2.4 million total enrollment, and P4HB is Planning for Healthy Babies, which is it's a family planning waiver. Yes. Yep.
Yes, ma'am. Yes. And that's under an 1115 waiver. Yeah.
Thank you, Mr. Chair. Y'all are putting this plan together as a proposal, I'd like to see a list of metrics that you think shows your success. Right? I got a mic up? Sorry. Y'all heard that.
Yes, sir.
So if you're putting the proposal together, what I'd like to see, y'all know your business, give us a list of things that you think shows that you're doing your job well, right? And that would give us the starting point for us to delve into, just the amount of emergency care at a specific hospital actually says nothing, right? That's just a measurement. So that's what I want to see is performance measurements from y'all first before we get into this. Last and second question, if I may, Mr. Chair, is you said the cap on the FMAP is based on the poverty and the population, but is this state actually matching as much as we can to pull down the most federal dollars? Are we at 100% of our match currently?
Generally, the answer to that question is yes. There are decisions that would have to be made either by the General Assembly or the administration because there's different programmatic categories of aid that have different federal FMAP percentages, right? So the expansion population has a higher FMAP percentage. Traditional Medicaid has a lower FMAP percentage. It gets far more complicated than that, where you talk about administrative funding, where you can get 90-10 match or 75-25 match. But by and large, the state has attempted to maximize federal revenue within the confines of the current program. For your first part, we would love to highlight some of our achievements. We oftentimes feel like we just talk about where we fall short, so we would be happy to present to you some of our successes.
Thank you. You briefly mentioned dual eligibles, but are the CMOs also DSNPs as well? Dual eligible? I'm a Blue Cross guy. I talk funny, use funny words. Are those numbers included in the data you're providing here?
I don't believe that we have DSNP plans, but let me double check.
All right. And also you're using HEDIS standards. You also use NCQA as well?
Yes.
Yes.
Okay. All right. Thank you.
There's kind of, HEDIS is by and large most
Yeah.
of those metrics, but there's
Yeah.
others that are relevant that we
Okay.
include as well.
Thank you. I'm going to read these really quick. When you talk about fee-for-service, is that straight or traditional Medicaid?
Ma'am.
Fee-for-service, is that the same thing as straight Medicaid or
Yes.
traditional? Okay. I was going to ask about the 2013 data. Will we ever get more updated data?
That's the goal here. We would typically use what we want to use audited data for this. And so there's generally like a 2-year lag on that. Unfortunately, if you want reliable data, that's kind of the pricing mission, so to speak.
And will the 2020, 2021 data be an anomaly since it was COVID?
Yes.
The last question is going to go to Representative Clark.
Thank you, Mr. Chair. I'll be really brief. This actually kind of goes, adds to what Representative Hutchison was asking. The data for next year is also not just going to include, the increase in the number of people that were enrolled in Medicaid, but also, sorry, I'm really close to the camera, but also include people who are suffering from, let's say, long COVID and things like that. Have you all had any talks about how COVID, the long-term effects of COVID are going to affect Georgia's Medicaid system?
That's an excellent question. I don't know that we've had, we're kind of still dealing with the pandemic as it comes. And, the redetermination is a huge issue. Long COVID is not something we've had a specific discussion about. I think we'd be happy to discuss that with you in further detail and include that, in a way that will be relevant for you all going forward in this project.
Thank you.
That ends our question and answer period. And I want to thank our two presenters very much for coming today. I know that you flew in from Washington. You're getting ready to fly out again somewhere else this afternoon, but thank you so much for coming. Look forward to working with you in the future and the information this committee and the rest of this house will be getting. Thank you.
Thank you, Mr. Chairman.
That ends our meeting. Thank you.